We talked about, last time we finished up with what? Osteonecrosis of femoral condyle. What's the most common condyle that's affected in the finger? Medial. Okay, good. So just understand that, when you're looking at imaging, when you're talking about osteonecrosis, you're going to focus on the medial femoral condyle. So I did include some videos for some of the upcoming physical exams as well, because I feel those are helpful. So you guys will see that hopefully today as part of the updated slides. So, okay, patella cornerstone tendonitis. So we're talking about tendonitis, right? That's inflammation of the tendon. Okay, that's not to be confused with ruptures, which we'll discuss a little bit later. Okay, so when we talk about these, we talk about them together. And why is that? You guys are aware of the extensor mechanism of the knee, correct? So it's comprised of the quadriceps tendon, the patella, and then the patella tendon inserting into the tibial tubercle. So they kind of go together, but they may be distinct pathologies, correct? All right, so it's important to understand that, again, when we're talking about this tendonitis stuff, it's an inflammation on somewhere along that extensor mechanism. It's also called jumper's knee. I have heard it called that. That's something we do use every once in a while. Okay, so especially athletes that do explosive maneuvers, sprinters, powerlifters sometimes, okay, people that do bad lifting especially. So, but it's pain. You have to start focusing on this anatomy stuff, right? So it's pain at the insertion to the superior pole of the patella, right? And so if it's the superior pole of the patella, which tendon is it? Quadriceps. And so if it's the inferior pole of the patella or the insertion at the tibial tubercle, then we're talking about the patella tendon, correct? So again, read the question, please. That way you don't get confused and answer the wrong thing, okay? Not just on my test, but again, on PANCE. So what is the typical population? Younger, less than 40, okay? Younger, less than 40. They get the tendonitis. So again, it's tendonitis. Don't get that confused when we start talking about the ruptures of both tendons, okay? So jumping, kicking sports, like I said before, erratic exercise habits. That's probably what most IPAP students have right now. Okay, it's where you kind of do things where you're not conditioned or you're not warmed up. Okay, and you're doing explosive maneuvers and you're not as flexible as you need to be at the time. Make sense? Okay, so erratic maneuvers. Okay, older, lifting strains, change in exercise level, substantial weight gain. I think it's funny that they add that in there. Okay, because again, I always tell patients every pound here, right? Every pound right about here. I'm joking. Is 8 pounds right about here. Okay, and that goes across both knees. So you start doing the math, 20 pounds overweight, my math serves me, that's 160 pounds on one knee, correct? But that's actually 320 pounds across both knees. It's pretty significant, isn't it? Okay, so when you start thinking about it in those terms, and you kinesiology students in here are like, oh, I remember that from my undergraduate. Okay, but that's the math of it, right? It's not 1 for 1, okay? Any questions about this slide? Okay, hallmark is anterior knee pain. So again, is that helpful? No. Read the question, dig a little deeper, focus in on the anatomy, hints that are being given, and this scenario is going to drive you to the correct answer, okay? Anterior knee pain, yes, it is the hallmark, but it's non-specific or sensitive, okay? Begins immediately after exercise. Again, this is tendonitis, so it's the itis, okay? And after what? Sitting preceded by exercise. Okay, so if you do a lot of dynamic maneuvers, or I guess like erratic activities, and then you sit down right away, they may describe a sharp, throbbing, achy anterior knee pain. Okay, things that make it worse, right there, makes sense. We talked about that. Brain circles again to highlight the tendons that we're talking about. No questions? Okay, so when we talk about physical exam, right, so what you're going to do in your physical exam is you're going to zero in on this anatomical landmarks that I discussed, okay, and that's going to drive your decision making. If I tell you a patient has tendon palpation proximal to the patella along the vastus medialis, right, the VMO as we say, right, then you're going to start thinking to yourself, okay, that's quadriceps tendonitis. Good to go? Okay. You're making me cold looking at you. She's got a full blanket on. So they could have mild swelling, they could have some crepitus. Okay, what's crepitus? It's like crinkling, right? So crepitus, is that something that you feel or the patient feels? Both, right? But it's not necessarily something you hear. You can hear it, you will. Okay? But I'm just telling you, you don't have to. Okay? So the big thing here is I'll have pain with existed, excuse me, my face is frozen. Pain with resisted extension. Okay? You see that maneuver is being demonstrated on the bottom right there? That's how you can do it with the patient lying down. Okay? Another way to do it is you basically have them with their legs hanging on the side of the exam table. Right? And I tell them to sit on the edge of the table like you're sitting on a dock. DOC. Okay. That's my English, right? And kick against me. Okay? So it's resisted extension. Now have pain. What you want to do when you tell them to do that maneuver is what? Where do you feel the pain? Oh, excuse me. What do you feel and where do you feel it? Don't tell the patient where do you feel your pain, like I just said. Don't do that, because what are they going to tell you? They're going to tell you they feel pain, right? You want to know exactly what they feel, okay? And with pain with extremes of passive flexion. So you would agree that if you lay the patient flat and you take their leg, right, and you bend it, hyperflex it, and basically take their heel and drive it into their buttocks, that would be hyperflexion, correct? Okay, so again, what do you feel and where do you feel it? Because if you do that maneuver and they feel pain at the hip, this may be different, maybe something else, okay? IT band, things like that. There you go, we talked about that already. Okay, so don't get confused with that. Okay, diagnostics, AP and lateral radiographs of the knee, always get those. Enthesophytes, again, see the arrows there? Does that correspond to where the tendons insert? Yes, so that's what we call a tug effect. Sports medicine, they call that tug effect. So if it's going on for long enough, you can actually see these little tips here, right? They're not osteophytes necessarily, right? Those are called enthesophytes. You see those? Okay, and that's again that pulling, right? So if it's at the insertion of the teletendon here and here, okay, and you see that in an adult, you would agree that in this X-ray you don't see open growth plates, correct? So this is an adult. We do not call adults Osgood-Schlatter patients or Osgood-Schlatter disease. We say you have a history of Osgood-Schlatter disease in youth, and then usually report some history of having some knee issues, right? Maybe when playing football or they run cross country or something like that. But this is an important distinction for you guys. In adult patients, you do not say that the patient has OSD. You say that the patient has patellar tendonitis. Make sense? And it's okay to qualify it and say, and they have a history of OSD, Osgood-Schlatter disease, evidenced by their X-ray where you see, as I labeled there, right? You see that evidence right there? That's where it was tugging on the bone as it inserts there at the tibial tube. Are we good with that distinction? So again, if you tell me that a 33-year-old male has Osgood-Schlatter disease, has it, not a history of it, has it, I'm going to be sad. Okay, but MRI is usually just reserved for patients that have recalcitrant cases. What that means is it keeps coming back. It doesn't respond to treatment. Okay, so then you would get an MRI to investigate a little bit further. Okay, and again, to clarify, we're talking about tendonitis, not ruptures. Okay. Are we good with these imaging slides? These aren't fair game, guys. You will potentially see these on hands. Okay, I've seen them. I'm doing a test review. I got a question on it. Luckily, I got it right. I wasn't sad. Okay. So outcomes of disease, if it goes on long enough, obviously they can have prolonged pain. And a lot of patients that go on to have patellar or quadricep tendon ruptures have a history of tendonitis. That's going to be in their history. Okay, so again, if it goes on long enough and they do it without one explosive maneuver, they can have a rupture. Okay, good with that? So you want to make sure that you're aggressively treating these patients, especially when they're younger. Make sure they work on the things that we're going to talk about next. So treatment-wise, it's all that good stuff, right? NSAIDs, RICE, activity modification, physical therapy. Okay. For these patients, is it acceptable? I had a student ask me, I was working with this provider. They would just give them a home exercise program, these handouts. That's okay, especially if you're on the line or you're at a VAS or something like that, and you're seeing sick call and you're handing out exercises. But if patients don't respond to that, then you must send them to physical therapy. Make sense? You don't just skip and say, well, they did PT. No, they didn't do PT. They did a handout of exercises you gave them. Good to go? So you limit their activity until they start regaining what? Pain-free range of motion, flexibility. All right, that's the focus initially. Then you work on strengthening. Okay? It's challenging because you're going to tell them to stop doing certain things that they want to be doing, correct? But you tell them to say, well, especially how significant their tendonitis is, if it's really bad, do they have a risk of rupture?
Yes.
Yes, so you're going to counsel them, you're going to educate them, you're going to reassure them that as long as they take the time to recuperate, okay, that they'll lessen that chance of rupture, okay? Good to go? What do we focus on? It's in yellow. You may see this again. You may be asked this in your rotation, okay? I asked this to all students that rotated with me as a preceptor. You said you want to send them to physical therapy. What do you want to tell physical therapy to focus on? What's the answer? Quads and hamstrings, correct. IT then, you can throw that in there too, okay? And you want to tell the patient that you'll put them on a program, or that physical therapy will put on a program to resume more strenuous activity as their condition dictates. Good to go? So we call that formal physical therapy, formal guided physical therapy, okay? I gave you some example there. Well, I was already there. But whyexercise.com, right? So some stuff that they may instruct them on doing. I think I told you guys this before. If you have a patient that you sent to physical therapy and you have a question as to whether or not they're compliant with their physical therapy because they're on a profile, for example, right? We all love profiles, right? Right? Do I take them off profile? Am I going to put them at risk for injury? Have them demonstrate their exercises. If they cannot demonstrate their exercises, they are non-compliant. There is an ICD-10 code for that. Put that in their chart. Okay? That way you know if they go on to have a rupture, you counsel the patient and you advise them that they are non-compliant, therefore they run the risk of further injury. Good to go? Tendon rupture, steroid injection is performed? Sure. Anytime you're injecting in and around tendons, that's always a risk. I will tell you that I do not advise you at the primary care level to be doing these injections, okay, in and around the quad and patella tendons. Okay, because even in orthopedics, we don't necessarily do corticosteroid injections. You guys know about PRP, right? I do not incorporate PRP into my lecture because it is controversial in the military as well. There's been some cutback on that. But you guys know that we do other injections, right? So we don't necessarily do corticosteroid injections. Okay, sir?
What's the limitation on these profiles?
For actually issuing profiles. So his question is, can physical therapy issue profiles? I would tell you, in my experience, you know, being a commander of this and director of that and whatever else, physical therapy at the training level, usually they have some authority to give profiles, okay? Because that just makes, you know, there's just too many trainees, not enough providers, right? But at larger commands, you may get patients that come back to you for a profile update, even though they're in physical therapy. Okay, makes sense? Because physical therapists are like, well, I don't do profiles, go back and see your PCM. Does that make sense? Don't worry, you guys will have a ledger. Right? You're efficient, because is the internet always up?
No.
No, right? So if you have trouble patients, right, or you're at a training command, and I was the chief medical officer for Squadron Infantry West, assigned to the U.S. Marine Corps, I would brief the commander about all the patients that were on profiles every week, right? So I kept my ledger, right? And you'll do the same, especially if you're like attached to special operations or something like that, because that's a go, no-go situation. You're briefing commanders on the ability to execute the mission. Make sense? Did I answer your question? Got a little crazy there, so I start reminiscing. So, but you will also have some persistent functional impairment. Okay, so obviously if the patient's having that, you tell them, say, well, if you continue to do these activities, not only will you be impaired, you could be disabled. You could be unable to do these things and require further treatment. Make sense? Scare your patients, it's okay. Okay, so we just talked about tendonitis. Then I moved ruptures to follow tendonitis. It used to be spaced out, because then we're talking about a spectrum, right? You would agree if there's a spectrum, right? My left hand is tendonitis, my right hand is rupture, then that's a spectrum. Somewhere in between there, most patients lie, correct? So now if we get to tendon rupture, is that what grade of injury is that? The tendon, right? 4? Sure. Right? It's 4, right? Or high grade or complete. Okay, those are all the same thing. You agree? Okay. Someone made me sad. They said 3. Okay. All right. Fine. And hold on to it. Get in the ready position. No, these are different days. Okay, so definition of a rupture, not to belabor the point, but it's like I said, this is a high-grade injury, and more importantly, it's a disruption, somewhere along that extensor mechanism we discussed earlier, right? So what are some things that can happen? Not only can they have a tendon rupture, but if they sustain like a fracture of the patella itself, then the patella is incompetent, correct? Okay, so therefore that can be present. Or they can have a quad or patellar tendon rupture. I've never seen a patellar and a quad together in the absence of major trauma. The reason I say that is because if the patella is split down the middle, aren't both ends affected? Yes. So isolated quad together with isolated patellar and the patella is intact, I've never seen it. But I just kind of try to explain that, you can have one or the other as well. Okay, fall into a partially flexed knee. So we call that in orthopedics fall on bent knee. You'll document it that way. Okay, mechanism of injury, fall on bent knee. Direct blow to the kneecap, okay, or better said, the patella. So here's your numbers. Quad. What is quad? Is that Caucasian or African American, black? Your book uses different terminology. So quad is white male, 40 to 60 years old. Patella is black male, 40 to 60 years old. You would agree if they're both 40 to 60, but that one is different than the other, right? I would know this, okay? Because again, Nance likes to ask these kind of questions. What is the most common? Okay, so do I agree with this necessarily? Not really, in the sense that my population for the last 28 years has been primarily military. So military tend to break this rule, okay? Fine, you guys know that. We talked about that with shoulder pathology, right? The military tend to have different spectrums of injuries, but your textbook teaches it this way, so I will test it this way, okay? What is the clinical triad? Palpable defect, inability to extend, and a change of patellar height on x-ray. I took a lot of time cleaning these slides up, so I hope it comes across good in the next few slides, okay? A lot of time, because this stuff, yes, you can memorize that, but then can you identify that both on physical exam and on your radiographs? That's also important, okay? Someday these tests will end, and the big test will be you standing in front of a patient and says, "What's wrong with you, doc?" You gotta be able to explain it to them. Pull up their x-rays, explain it to them. Tell them what you found on physical exam. That's important, okay? Make sense? Well, these pictures here, you would agree that my pointer doesn't work? That this is the quad tendon that's ruptured up here. That's the patella tendon that's ruptured down here, right? And again, on this side, quad tendon is ruptured there, and over up here, the patella tendon is down there. Excuse me, the patella tendon is ruptured. For the most part, your book tends to focus on rupture of the insertions. Can you have intrasubstance, kind of mid patella tendon ruptures? Yes, right? But more commonly, you'll see stuff in the quad area. Right, but for purpose of testing, I'm just going to keep it simple and just say, is it quad or is it patellar? Okay, make sense? Okay. Large effusion and palpable defect. You see that picture I found for you guys? I mean, would you agree that that shouldn't be like that?
Yes.
Okay, so you're literally running down the course of the quads. You approach the patella and whoop, you fall into a crevice or a crater. Okay. And you're like, well, what is a palpable defect? That is a palpable defect. There's a defect in the tendon that you can appreciate on physical exam. Same thing over here with the patella tendon. Should you be able to stick your thumb down there and touch the part of the tibia that's not normally exposed, that's not normally, covered by the tendon itself? No, you should not be able to do that. So that is a palpable defect, okay? So the ability to extend against gravity over the straight leg raise, okay? I didn't put on the slide, but I will teach you this. when you are documenting this, you say this: the patient is able to extend the knee against resistance. Okay? He's able to obtain and maintain a straight leg raise. Obtain and maintain a straight leg raise. That means that they can put their leg into a straight position. They can elevate it at least 4 inches off the bed itself. All right, and that means the extensor mechanism is intact. Make sense? Okay, so teaching you something for phase 2 as well. They're able to obtain and maintain a straight leg raise. That means the extensor mechanism is intact. Correct?
Yes.
So you're like, okay, I think you could have some tendonitis. Is it possible they have a partial tear? Sure, right? You can just protect the patient and get further imaging. Okay, but if they're unable to obtain and maintain a straight leg raise, okay, then you have a rupture, and you have to figure out which end it is, right? Is it the proximal end or the distal end? Is it the quad tendon as it inserts into the superior pole of the patella, or is it the patella tendon as it inserts into the inferior pole of the patella? Are we good with those definitions? Obtain and maintain a straight leg raise. Okay? You'll impress your preceptor if you say that, I promise. Because most of us don't expect that. Okay? And, oh, he can move his leg. I'm like, yeah, good. He's not dead. Right? So can you still move the leg in some planes? Yes. But the extensor mechanism is what you're testing for. Make sense? Okay. So moving on, radiographs, AP and lateral 30-degree view. So when we say that 30-degree view, that's that slight bend in the knee, correct? Every X-ray you've seen, right, has had a slight bend in the knee itself. Okay. So when you shoot those films, you want to make sure that the condyles overlap, right? Distal femoral condyles. That way you know you have a true lateral. Good to go. So patella alta. ¿Alguien aquí habla español? Sí, un poquito. Ok, entonces vamos a hablar español para el resto del lecture, okay? But having said that, alta means high and baja means low, okay? So there you go, okay? I speak 8 languages, so we can make it quite easy. But patella alta corresponds to patellar rupture, correct? Why? Because it's on the slide? Yes, of course. But if you look at this picture that I put on here, if the patella is ruptured, which one's still intact? The quad, correct? Okay, so that it's still pulling. So it's going to pull proximally. So it's going to be high compared to the knee joint, correct?
Yes.
Okay, so that's patella alta. So therefore, if you have patella baja, then it's a quadricep rupture because the patella tendon is still intact and it's still pulling, correct? And it's still pulling inferiorly, so it's going to be lower than the joint line. Okay, joint line is not really the terminology we use. I'll get into that in the next slide. MRI, it says rarely used. Okay. Okay, I struggle with that because again, this is not a surgery class. I'm not teaching you guys to be surgical PAs. Okay, but I'll tell you we usually get MRI, right? But rarely used to make the initial diagnosis, and I think what they're getting at. I'll stick to that. Okay. So moving on. This is what I took time with. This line here, again, I'm not going to get too much into it, but when I look at a knee X-ray, I see a lot of things you guys aren't even thinking about. I can spend hours talking about that one view, right? There's so many things that we look for. But that line that I'm drawing there in black is a line that I draw in my mind. Okay? That line extends out and it bisects, or it makes contact with the distal third of the patella. That's normal. Okay? You draw that line, that's why it has to be at 30 degrees. Does that make sense? So why you say, well, why do you have such stickers on true laterals of the knee? That's why. I can't draw that line either on my mind or with the computer, right, with the assisted little tools, unless the patient's properly positioned in the radiograph. Make sense? So if that's normal, then you would agree that if you still draw that line, okay, and you say, well, that line does not intersect the distal third of the patella, therefore the patella must be alta, correct? So that is a patella tendon rupture, correct? Right? Yeah. So then if you go to the last one, right, you say, well, it's actually intersecting the proximal third of the patella, and it's low, right? So what's intact then? The patella tendon, right? Does that make sense? So that's where that comes from. Insults to the body, right? That's the name of that index that we're checking. I will not test you on that. That's why I removed all that from this slide. But I'm just letting you know, when you call me and you say, I got x-rays, and I'm like, yeah, you got terrible x-rays. You get a true lateral. That's why. Because I can't make the diagnosis myself until you get the right x-ray. So what's going to happen is, and you still don't have any x-ray techs in here that want to fess up? Nobody's an x-ray tech? Okay. So the x-ray tech's going to say, well, I couldn't put the patient in a certain position because they hurt too much. And my answer is, well, can we try again, please? You know, be nice, right? Otherwise, I just walk down to radiology and shoot the x-ray myself. Because I need to get this x-ray, right? Why? Because I'm doing these things. Otherwise, I gotta get what? An MRI, right? Am I gonna get one anyways? Nah, I told you already. Right? But I'm just telling you, this is making the initial diagnosis, right? To make sure that we don't have something else going on. Oh, and by the way, does he have a patella fracture, right? Because that changes the game, correct? Yeah. Completely. Because then you're doing all kinds of stuff, okay? Does he have a tibial plateau fracture? Right? Does he have anything else? A femoral condyle fracture? There's all kinds of things we're looking for. Does that make sense? Am I going to test you necessarily on your ability to draw these lines? No. But in support of the question, you may get an x-ray. And if you know this, you're going to answer that question within 20 seconds. I hope. Right? Because the question is going to say, where's the tenderness? They're unable to extend against resistance. They're unable to obtain and maintain the straight leg raise. Here's an x-ray. What do you think the diagnosis is? You're going to look at this x-ray, you're not going to read the question. You're just going to look at this x-ray and you're like, boom, patella. Okay? That's it. Nailed it. Okay? Good to go? All right. What's the outcome of disease? Well, your extensor mechanism is not intact. Can you walk? No. Permanent loss of knee extension. So disability, correct? We hate disability. That's what we fight. Stiffness and disability. Do we fight disease? Sure. Right? But we fight stiffness and disability. So treatment, non-operative. Well, again, we're talking about ruptures, right? So what kind of patients do you think could live without the ability to walk normally? Not many, but what if they're low demand? Right? 60 years old in a SNF. You guys know what a SNF is? Skilled nursing facility, otherwise known as a nursing home. Okay? So maybe if they're, wheelchair bound, they happen to fall on a bent knee out of the wheelchair, but they're older, right? Distinguished, of course. And they're low demand, and the risk of surgery could kill them, right? Because they're not healthy people. Then we say, well, non-operative treatment has been selected, okay? But can you have a partial? Sure, that's more what I focus on. So an incomplete rupture. That terminology I struggle with, because we don't really talk like that, okay? It's either out or it's in. Incomplete rupture to me means partial tear. Does that make sense? I would never get that tricky on your test, but just understand that terminology is out there, and so it can get a little confusing. Incomplete rupture is a misnomer in my opinion. Makes sense? Okay, so what are you going to do? You're still going to try to get them motion, right? They can still do some things, okay? So you're going to drop them to physical therapy, you're going to do the NSAIDs, right? You're going to do the activity modification. If they're in a skilled nursing facility, for example, you're going to prescribe certain things, okay? Some of you guys are National Guard, correct? Yeah, so you're going to go out there and you're going to work in the civilian sector. So you might have to write admission orders someday, okay? So things to think about. Do we use knee immobilizers and cylinder casts? We do, but usually in the short term. Okay, if that's something, if we have to do non-operative care, it's certainly something we can do as well. What is the difference between a hinge knee brace and a knee immobilizer? One can bend and the other one cannot. Perfect. So a knee immobilizer is that big sleeve, right? You guys have seen people walking around in. It goes from about here all the way down to almost their ankle a lot of times, okay? And it has two metal shanks going down both the medial and the lateral aspect, and it prevents lateral medial translation and any kind of flexion extension. Make sense? Now, let's think about this. If you put somebody in knee immobilizer with legs fully straight, okay, they're not able to bend, none of that stuff, and they still bear weight? Yeah. Yeah, because you're providing them stability, correct? Now, does it look good? No, they're doing this. Okay, all right. So, but but if they have crutches, right, they can still potentially get around. Does that make sense? Okay. So operative, all complete ruptures or fractures, that's kind of, fractures part is kind of straightforward, right? But what's the time frame for getting to these patients? Within a week, right? So tendons like to, something's still attached, correct? Still pulling, things retract. Everybody knows what I mean by retract, right? It's pulled back in either direction, pull down or pull up, right? So pull proximally or pull distally, right? And things start to heal. Right? So if you get to it later, it can be more complicated because you might have to augment the tissue with other things. We talked about grafts, right? So it becomes more of a complicated surgery. So we always like to get those within a week for at least initial evaluation. That surgical stuff can be pushed out a little bit from a week. The point of this slide is, as soon as you make a diagnosis, you need to send it. Don't do a routine consult, pick up the phone, call somebody, okay? Good to go? Any questions about this so far? Okay, treatment stuff that can go bad with treatment, or just adverse outcomes as your book says it. Obviously, they can get what? Infection. They make incisions, right? And drill holes. Fun stuff. Can they get a DVT? Sure. Are they going to be as active as they were prior to injury? No. So a lot of these times, these patients, as long as they're able to tolerate it, we put them on aspirin, DVT prophylaxis, okay? So they're at the highest risk for re-tear or re-rupture, right, within the first 6 months of injury. That is talking about more so, obviously, with surgical fixation, correct? All right, so we tell patients, their physical therapy is going to be a prolonged process, okay? But they're at the highest risk of re-tear or re-rupture in how many months?
6.
6, perfect, okay. So red flags, again, get them to us. Call somebody. Don't put a routine consult in. There you go. Okay. You get them in your primary care clinic, you make diagnosis, you do not have a knee immobilizer, you do not have crutches, you do not have a wheelchair. Where do you send them? ER. Call them and let them know it's coming. Okay, it's just courtesy. Okay. There you go. You don't be that provider who just says, go somewhere else. Right? So, okay, don't do that. Call ahead. That way they get ahead of the line. Okay? Not compared to heart attacks and that stuff, but what's the ER going to do with them? Nothing. They're going to do absolutely nothing. They're going to page surgery. So the sooner they can just page, they're actually going to appreciate that. Some of them are church, right? So, but they're going to appreciate that because then you kind of like help them with their disposition. You told them, hey, I got a patella tendon rupture coming. Ooh. We're advancing. We have a resident workforce that has nothing better to do but come down and take care of our patients for us. Right? Punt. Okay? You guys have heard the term punt already? Punting. Okay? So, that was 2 topics. Took my time with it. Because I promise you, you'll see that soon. Okay? Patella tendon stuff, quad tendon stuff, you need to know this stuff. Okay? Because if you see this in practice, you need to know how to disposition it. Okay? Do we want to go ahead and break? Post-dictal, post-lunch. All right, so break or push? Push. Perfect. I love it. Okay. Patellofemoral tracking, maltracking, excuse me. Patellofemoral tracking is a thing. So that's the patella as it tracks along that groove that we've discussed before in MSK radiology, right? That groove, or that notch, if you will, where the patella sits in. Okay, as you flex and extend, the patella glides in that notch, correct? Okay, so that's normal patella tracking. So therefore, if you have normal patella tracking, then you can have abnormal patella tracking, which is called maltracking, patellar maltracking. Okay, so that's what we're getting into now. Okay, patellar maltracking. So again, that's this is the sunrise view here, right? All right, sunrise view. So it's an abnormal motion of the patella in that area, in that anatomical landmark, if you will, as the patient is moving, whether it's flexion extension or performing dynamic motion. Okay? So you can have a subluxation or dislocation. Okay? So subluxation is it wants to go out, but it catches itself, right? We call that perching. It gets stuck right on the edge, but doesn't quite dislocate. Okay, so that's a subluxation. And a dislocation is it's out. Okay? you guys are gonna laugh, but the first time you ask the patient, have you ever had a history of shoulder dislocation, because you guys are gonna be good at shoulder exams, right? They're gonna tell you, I don't know. Trust me, you would know. It's out, okay? Someone else has to put it back in. But when it comes to patellar dislocations, sometimes, honestly, the patient will self-reduce, right? So they'll actually take their knee and extend it, and it actually pops back in, okay? So this may be kind of an outlier, okay? But usually what they'll say, though, I looked down, and my kneecap, right, my patella was lateral to my knee, okay? Because what is the most common direction of dislocation? Lateral, okay? So do you think that the forces that restrain that motion are therefore found on the medial side? Yes, and we'll get to that right now, actually. Because that structure is called the MPFL, okay? Medial patellofemoral ligament, okay? So medial patellofemoral ligament is either stretched or it's torn, right? So we can grade that, correct? So if it's ruptured, that's a high-grade injury of the MPFL. Okay. Do you think, we discussed the string sign before, right? Where I told you guys when things get pulled and then they go back, they kind of get a wavy appearance to them. So we might get an MRI and we can see that MPFL, we can see that little string sign, as we call it. Okay. Am I going to ask you that on the test? No, but just let you know. Okay. Because what happens is, as the kneecap goes laterally, it pulls on the MPFL. Hopefully, it catches itself before it ruptures, but if it goes out all the way, then they have an MPFL injury. Okay, good to go. So it's not just a patella thing. Any questions about this slide? I'm sorry. Here, the arrows are pretty self-explanatory, right? It's going lateral. How do I know that's lateral? What's this bone here called? What's this bone here called? Fibula, not the tibula. Okay? Now there's no fibula and there's no tibula. Okay? All right. You laugh, but I hear all kinds of stuff. Patellar instability. So therefore, if they have maltracking, and especially if they have a history of a dislocation, it's not just that it's moving abnormally, but bless you, COVID. But it has disrupted the MPFL, so therefore they have instability. Okay? So now we're talking about patellar instability at the top there. Obvious dislocation, transient dislocation with a spontaneous reduction. That was what I talked about before. That's self-reduction. It's spontaneous reduction is the way you'll document that. Okay? The patient said they looked down, they're like, ooh, my patella is not supposed to be lateral to my knee. And then they went to extend their knee, their leg, because they stood up, right? From their injury. Right? They stood up, all of a sudden, boop, it popped back in. But it was super painful. It hurts. Okay? Right? So that's a spontaneous reduction. Okay? But then that's the spectrum of patellar instability. If you're just talking about maltracking, right, that just means you have abnormal motion, correct? Yeah, it took a lot of time with this slide to make sure I separate these two. So when they have patellar maltracking, let's go back to this picture. Is that cartilage right there? Yes. Is that cartilage right there?
Yes.
Yes. So again, same thing. That's cartilage right there, that white. That's cartilage right there, right? So as they're doing certain motions, right, they'll describe pain behind their kneecap, right? Especially when they're going to hyperflexion, deep knee squatting, things like that, okay? Because the patella is being driven down into that groove there, okay? So that we call that retropatellar pain. Okay, so it's behind the kneecap, retropatellar pain. Okay, with quad activity. So as they actually fire their quads, right, it also pulls down into that groove, to that knot. That can cause pain. Okay, makes sense. Do you think we have a test where we grind on the patella and down into there? Yeah, we do. We love to cause pain in orthopedics. Don't send them to us for pain, but we'll cause more pain. So what kind of activities? They'll say it gets worse with going up and down stairs, but specifically worse with going downstairs. And when you're going down the stairs, you guys understand the concept of acceleration and deceleration, right? So you have to accelerate to go up the stairs. When you're going down the stairs, gravity is 9.8 meters per second squared, correct? So you're fighting gravity at all times, okay? So as they're going down, they're actually trying to decelerate. They're trying to stop their motion, so they're contracting more forcefully, potentially. So that's why it hurts more when they're going downstairs. There you go. Got a little physics in there today. You're welcome. So theater sign, so when they're seated, obviously the quad and the entire extensor mechanism is driving that patella down into that groove, correct? So that's called the theater sign. As they're seated, they say they have more pain. And when they get up and move, not when they get up and start squatting, but when they get up and just walk and extend, that relieves that pain. So a theater sign is like sitting in a movie theater. You're sitting there with your extensor mechanism completely on tension, and that can cause pain. Okay? So you will document that. Positive theater sign. Okay? And then again, like I said, they'll say that pain is squatting. Okay? So physical exam, instability, right? Why are they going to have tenderness to the medial aspect? Because that's where the MPFL is, correct? So along the area where the MPFL courses, they'll actually have pain. If they have an acute rupture, do you think they're going to have ecchymosis and swelling? Yes. So you're going to document that, right? So patellar apprehension test, you see how this patient, their leg is off the edge of the bed. They're about 30 degrees flexion there, and they're actually taking their thumb and trying to drive the patella laterally. Do you think if somebody especially if they just dislocated their patella, that they're going to have pain?
Yes.
And they're going to be apprehensive?
Yes.
Hence the name. Okay? 30 degrees. Do you have to hang them off the side? No. Okay? But that's just, if you want to just use that, that's fine. You can lay them straight on the table too and put your knee underneath their knee, correct? Put your knee underneath their knee. Yes, I said that correct. Okay, just then hold them at 30 degrees and then flexion. Okay? And make sure that you push on the patella laterally, and then if they have apprehension, you document that. That is a positive finding. Positive finding is not pain, it is apprehension, hence the name. Does that make sense? So you can document pain with apprehension. So if they just have pain, could they have maltracking? And then that's not instability, correct? So this is specifically for instability. Okay? So maltracking, you're going to do alignment testing. We don't get too much into the alignment in this block. We'll get more into it in the next block. You can talk about hip, knee, ankle alignment, right? Because you're going to start talking about foot and ankle stuff. But you do assess their alignment, right? You guys understand that we do have genu varus and genu valgum. So knock knees and low knees. So do you think certain patient types have a higher predisposition to patellar dislocation, patellar maltracking, therefore instability if they have a dislocation? Yes, because that's why it's important to assess instability. I put a video on there. It should work. Okay, painstakingly I got it to work. Okay, so when you click on that or copy and paste it, there's a video. Okay, you can watch what a J sign is. Okay, a J sign is, and again the video does a better job just of showing it, but a J sign is basically as the patient is flexing and extending their knee, if they have patellar maltracking, not a dislocation, right? This is found under maltracking, right? It's not found under instability. So you're not going to be doing that test during if they just dislocated, right? Unless you want to relocate them and cause them pain, right? But if you are flexing, extend the knee, and you're seeing the knee cap, right, the patella going in and out of that groove laterally, correct? And that popping sensation, then that is a positive J sign. Are we good with that? Okay. I can't demonstrate it because I have to. Does anybody here know that they have patella maltracking? I have to have a patient that has it, correct? So I found a video you guys can watch. Is anybody able to click on it and get it to go? Yeah. Okay. So you can watch that at your leisure. Okay.
The maltracking causes pain?
Say again.
The J sign.
J sign is that motion that you're seeing, that abdominal motion.
Okay.
They can have pain, correct. But what you're looking for is the J, right? So it's basically, and again, the video does a better justice, but it's where it's going from medial to lateral as the patient is extending and flexing the knee. Make sense? Okay, so it makes it kind of a J pattern. That part's not as important, right? Because the test is called J sign, so you're just seeing evidence of patellar maltracking. Make sense? Do you think those patients that they just have patellar maltracking and they don't have patellar instability and never had a history of patellar dislocation, that those are good candidates for physical therapy?
Yes.
What two muscle groups are you going to focus on? Hamstrings and quads. We're getting somewhere. Okay, you guys are already ahead of the curve. Haven't even got to that slide yet, right? So, but when you get the radiographs, this is what you're going to see. You would agree, because you guys are experts at looking at this view, that this is the lateral right here. That's the lateral aspect of that groove that we talk about here. Okay, of course you do. Okay, but you can see how it's perched. It's sitting to one side. It's not sitting perfectly in the center. So this patient may have had a history of patella dislocation, or they could just have patella maltracking. Okay, and that puts them at risk for patella dislocation, correct? Answer is yes. I've lost at least one person. All right, so, but you're looking, in this view, you're looking for that relationship between what? The patella and the femur. So this is also called a patellofemoral view. Okay? Shallow trochlea, so shallow. Would you agree that this is supposed to be further down here?
Yeah.
All right, so it's like a shallow pool. It's not a deep pool, it's a shallow pool. If it was deeper, it would encapsulate more of this crown here into that groove, correct?
Yeah.
This crown here into that groove as well. It's bad terminology, but I'm trying to explain it. All right, so if it's shallow, like it's showing in that picture there, it doesn't provide any further restraint to that motion, right? So again, it predisposes them. So this is what you get from getting this view. You can document they have a shallow trochlea, okay? And there's a lateral resting position of the patella. It just sits there, okay? Because you would agree that this shot is taken like this, right? All right. Daniel-san, praying position. Okay. All right. Sweep the leg. All right. So MRIs, do we get those? Yes. Especially if we're suspecting that there's an MPFL injury. Okay. The other reason we get an MRI, to be quite honest with you, is because the undersurface of this has cartilage, correct? Okay. The undersurface of this here, this patella, has cartilage, correct? Can you see cartilage on an X-ray? No. If there's a large chunk of cartilage that's sheared off, then you need surgery for that too. Because will that cartilage float around the knee and potentially cause catching and locking of the knee?
Yes.
Yeah, and that could mimic a meniscal injury, correct? Yeah. So a lot of times we get the MRI to look for that as well. That is not testable. You're welcome. Okay. I'm just telling you why we get MRIs. Okay. But you may see what they call kissing lesions. Okay. You see the edema both on the lateral femoral trochlea and the medial patella. That's where that traumatic dislocation occurred, and those bony surfaces made contact. So those are called kissing lesions, right? One area hit the other and caused trauma to that bony surface. Okay, so you'll see that on MRI. And again, you guys told me you guys talked about T1 and T2 weighted images, correct? So you understand you can see different things on different images with MRIs. Of course you can. Okay, none of that stuff. So outcomes of disease, obviously, if they have patella maltracking, it can be quite painful, right? So can it go on and have chronic pain? Yes. Does it put them at, again, a risk of a dislocation? Absolutely. Okay. So so if they're not doing certain activities, could their quads get weak?
Yes.
Yes, that's bad, right? And it can limit their sports activity, right? They tell you, say, well, I used to love to run, and now I can't run. Okay. So then they can also have patellofemoral arthrosis. Okay? So what's the difference between arthritis and arthrosis? Right? So arthritis is a joint, right? Arthrosis is an inflammation potentially of the tendinous structures and just a generalized inflammation of that area. Make sense? You can have arthrosis and it's not necessarily in the joint. Okay? But you would agree that this is a joint here, right? Right? That's the patellofemoral compartment. When we discussed arthritis, I told you there was 3 compartments. There's a medial, lateral, and patellofemoral compartment. Okay? That's the patellofemoral compartment. Okay? So, confused yet? Don't worry, we don't really use the term arthrosis. Yeah. We just say generalized swelling or something like that. Right? Because it's usually arthritis. Okay? But your book says it, so I teach it to you. Okay? But that's the difference. Did I confuse anybody? I'll try harder. Okay, treatment. So again, I broke it down. This one says maltracking, correct? So this is maltracking that we're talking about here. Okay? At the top there. Okay? When you're talking about acute patellosubluxation or dislocation, right? Do you think that they're at risk, the highest risk of subsequent subluxation or dislocation right after the initial event?
Yes.
Or episode, that's what we call them, events or episodes, okay? Yes, so you brace them in extension with modified weight bearing with reevaluation every 2 weeks. Okay, so a lot of times we use which brace that we talked about? The knee immobilizer, okay? Because it does not allow for any flexion. And then every 2 weeks, or the first 2 weeks, excuse me, then they come in and we say, okay, now we can transition you to a hinge knee brace so we can start some flexion. Okay, but we can lock the hinge knee brace to say 20 to 30 degrees. You guys notice how 20 to 30 degrees comes up a lot? Okay, because that's that initial tension that's put on that, right? We talked about that's why you tested in that range. So you lock it to less than 20 degrees for that first 20 weeks, and you advance 10 to 15 degrees every 2 weeks until they get full flexion back. So that's a safer way of doing it. You allow for soft tissue swelling to decrease, you allow for better motion, and you decrease the risk of subsequent subluxation or dislocation. Okay? Any questions about that? With chronic recurrent maltracking though, okay, this is not subluxation, okay, this is not dislocation, this is just maltracking. What's the course? Quad strengthening and flexibility, bracing, and physical therapy. When we say bracing there, we're not talking about a knee immobilizer, and we're not talking about a hinge knee brace. You guys know what a patellar sleeve is? Okay? It's literally that sleeve that you see people walking around with their kneecaps sticking out the center of it. Okay, something like that. Because it can provide stability to the patella, but still allows for full range of motion. Make sense? Anybody, did I lose anybody there? I'm trying to get some DME here. That way I can like hold it up during the courses. Okay, but right now we can't even get paid. Right? So I think we got it right. Yeah, maybe next semester, right? But basically a patellar sleeve with a hole cut out of it, right? So because it stabilizes the patella, it does not allow it to move laterally or medially. Other special patella knee braces or sleeves that you can get, absolutely 100%. We won't get into that. Okay. Is it okay to use an ACE rep? Yeah, right? Absolutely, 100%. Okay. Operative, well, now we're moving away from the non-operative stuff, right? And I differentiated how there's a difference between maltracking and the documented history of episodes or events of either subluxation versus dislocation, right? You guys are good with this. Okay, because now we're moving on to the operative stuff. So if we're talking about operative stuff, we're not talking about maltracking, right? With that first line there, MPFL ligament reconstruction, that's because they had a dislocation, right? They injured that ligament, and therefore it's incompetent, right? They have patellar insufficiency secondary to MPFL rupture. Okay? Realignment osteotomy, not to get too far into that. You'll talk more about the realignment type surgeries in block 4. But basically, if somebody has genu varus or genu valgum, and it puts them at a risk for patellar dislocation, subluxation, and then subsequent dislocation, do you think that you might be able to change that alignment of the leg, the knee, in relation to the hip and or the ankle, and potentially give them better alignment, therefore less of that chance of dislocation or subluxation? Yes, that's what they're talking about there. That's a huge thing. I could talk about that for 8 hours and still not even scratch the surface, right? There's a lot there, okay? So I would not test you on the surgical techniques, okay? NSAID risk, you guys know. Man, you're tired of seeing this on the slide, right? Renal, cardiac, all that stuff, okay? Know it, live it, love it, okay? Patellofemoral pain, obviously they can have pain, patellofemoral joint, due to maltracking. We talked about that. Even after we do surgery, they could have residual instability. Okay? That's bad, right? But we make them better. Okay? If you don't do a full-on realignment and you just do an MPFL reconstruction, you're just trying to provide stability, but maybe later on they're going to need some other surgery to actually do realignment. Make sense? So they can still have recurrent instability. But hopefully they don't have dislocation, they just have more of a subluxation picture. Make sense? Okay. So red flags, acute dislocation. I'll tell you this, and this is for clinical practice, I would not test you on this, but everybody gets one. Okay? Everybody gets one patellar dislocation. Okay? And then after that, you're 100% surgical in our opinion. I say our because I mean our discipline, okay? But do we still get an MRI after they did the first time? For the reason I said earlier, we're looking for cartilage defects, okay? Even if we don't suspect an MPFL rupture. And because if there's a big honking piece of cartilage floating around there, don't worry. It'll work its way into that notch that we talked about before, and they'll get locked out, right? So we gotta find that. And do we like to restore cartilage and make sure that the patient doesn't have early arthritis?
Sure.
Yeah, so we can find that big chiclet, tack it down early before it completely wears out. Okay, and then that's better for the patient, correct? The answer is yes. Acute, but if they have an acute dislocation, I would call orthopedics. Okay, for any acute dislocation, let us make the call. Okay, because if the patient will tell you, I had this spontaneous reduction, I think I'm fine, but then when you do apprehension tests, they're apprehensive, and so you're worried about subsequent dislocation. Do most family practice clinics carry knee immobilizers?
No.
No, and that's what I told you the patient needed, correct? So even if they're quote unquote FINE, right? Because every patient's fine, right? Especially operators, oh, I'm fine, I'm good. Like, yeah, you're good until the next time you dislocate, then 100% they're going to need surgery, right? So you're trying to prevent them from subsequent injury. So all acute dislocations I would refer, okay? If they're chronic dislocator subluxations, yeah, you're going to refer them. Right? But get a sense of their history. How many events or episodes of dislocation have you had in your lifetime? Okay, within the last 12 months, because some people are crazy. They will tell you, I've had some patients. I had a patient in the south, he dislocated like every other week, right? He just refused to keep following up. Can't get an MRI, tell him, okay, we're going to book you surgery, disappeared, right? Then he'd come back and say, oh, yeah, I got busy, I went on deployment, and I dislocated 8 times on deployment. But I reduced it myself on FINE. It's like, great, we got to get another MRI because you have dislocated it again, right? Every time you dislocate, you MRI, right? Because things change, right? So get a sense of like how many times and how frequently and how many times within the last like, I don't know, reasonable amount of time, 6 months, let's say, okay? Any questions about that? You guys did see the effort I put into differentiating between patella maltracking and subluxation versus dislocation, right? So make sure, don't get those two confused. Don't give me a non-operative treatment for a patient that has chronic subluxations or chronic dislocations, not just chronic maltracking, okay? We're definitely taking a break. Come back in 10 minutes. So talked about this spectrum of all these actual conditions, right? So then you're left with, you do all kinds of imaging studies, you do all kinds of diagnostics, you do physical exams, all those tests we talked about, you don't really got anything, right? So then what are you left with? This right here. They just have pain in or in around, involving, etc., the patellofemoral joint, okay? So that's literally called patellofemoral pain. When you guys were in boot, for some of you guys, especially me, I was quite some time ago, but you remember you would have teammates, right? They never run before in their life, only when chased, right? For the police, therefore they end up in the military, okay? So when they started doing all this running and stuff, they would say they have knee pain, right? Is that runner's knee? Sure. Is that jumper's knee? Maybe. Right? It's just this very nondescript. So there's a condition that we would diagnose people in the training environment because we couldn't find anything on their exam and we couldn't find anything on their imaging and they're young, right? And we just call it patellofemoral pain syndrome because they're just complaining about this and a couple other things too. Okay? Make sense? Right? So you couldn't nail down any of those diagnoses. They were able to obtain and maintain a straight leg raise, negative patellar apprehension test. They have no history of a subluxation or dislocation, etc., etc. Okay? Therefore, you end up here, patellofemoral pain. Okay? So, AKA patellofemoral pain syndrome, diffuse aching anterior knee pain that tells you nothing. Correct? Overuse, overloading of the patellofemoral joint. So therefore, when I say overload or overuse, again, weekend warriors, recruits, trainees, people that are not used to doing long distance running or any kind of physical exertion because the Xbox and the PlayStation is just too much fun, right? That's the newer generation, right? So therefore, now they're doing all this, they call it overtraining. They're just training. There's no such thing as overtraining in most basic trainings now, okay? All right, but they're doing overuse and overloading. But what you're not going to do is you're not going to equate patellofemoral pain syndrome, with chondromalacia. Ever, 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 ever. Right? You're never going to do that. You're never going to be that provider that says that a 21-year-old recruit has chondromalacia of the patella. Because what is chondromalacia? So chondromalacia, chondro means what again? Cartilage. Mal means bad, mal, right? On back to my Spanish, right? And acia, I don't know, just Malaysian, right? So basically there's dings and cartilage defects on the undersurface of the patella. You know, they don't have those with young people, correct? Those are older people. That's more of the arthritis picture. We all agree with that, right? So you're not going to equate ever, 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 ever PFPS with chondromalacia. Now, can they have patellofemoral pain? Like just pain, not PFPS, patellofemoral pain syndrome. Patellofemoral pain and have chondromalacia? Yes, that's fair game as long as the clinical picture is correct. How do you see cartilage? On what form of imaging? MRI. If you're diagnosed with someone with chondromalacia of the patella without an MRI, unless you're someone like me that has clinical experience and can tell the difference, it's probably not a good thing. Okay? So young recruits get what? PFPS. Okay? Good to go? Anterior knee pain. So there's that theater sign again, right? It's very, so theater sign's there again. So does that mean that that's very specific and sensitive?
No.
Super neither. Okay? It just means that when you put tension on the extensor mechanism and it drives down into that groove that we keep describing, that they have pain. Okay? Again, when you tell them to point to one area where they have their pain, they're just going to draw a circle around the entire patella. Okay? Right? Is that fine? Sure. Alright, so that's it. So it's very nondescript, right? So increase in activity level and weight training. That's what you're going to get. I told you guys when we started this journey like many, many weeks ago that is it important to get a good history from your patients? Yeah. Yes. You will train your medics, corpsmen, support staff to get decent histories at least of the mechanism, and when you have some sense of what you're walking into, because you will have an understanding that it is important to understand pre-existing OPTRST, right? Timing, right? Timing stuff. I just started a new workout program that involves Olympic weightlifting. Have you ever done this before? No. Okay. So that could be a causative factor. Goes with PFPS, okay? Or just put patellofemoral pain, okay? Do that, this kind of tricky, it says sometimes they have a history of direct load to the kneecap or patella, sure. Just make sure you rule out fractures, okay? Makes sense? Okay, so there's a good representation in that picture that when you flex there, that there's tension on the entire extensor mechanism. Any questions about this? Okay. Physical exam-wise, again, this is just pain, right? So that this is where you're really going to lean into the grind test. Is the grind test useful in diagnosing patellar instability? No, especially in an acute situation, right? But if they have chronic pain and you do a grind test and it's positive, and they have no instability on exam, negative patellar apprehension, right? And they're able to obtain and maintain a straight leg raise, therefore you're going to chalk it up to more patellofemoral pain. Make sense? So just to confuse you a little bit more, right? Then we get there that they again have a history of patellar maltracting or patellofemoral instability. Okay? You get the sense that the patellofemoral conditions can have some bleed and some crossover into each other?
Yes.
Okay. You do, right? That's why I said this one for last. Because is patellofemoral pain necessarily a diagnosis?
No.
No. PFPS is, but if you're making the diagnosis of PFPS, it means you ruled out all the above. Everything we just talked about. You've ruled out instability. You've ruled out maltracting. You've ruled out fractures. Okay? Make sense? See what we're getting at? Okay? Alright, hopefully that's clear. So sunrise view again can help you rule out the malalignment stuff we talked about and early arthritis. We talked about treatment. Hallmark of treatment for PFPS is what? Physical therapy. Okay. I did see that on a pants review question, believe it or not. It sounds like a very simple thing, right? But they try to be tricky and say like occupational therapy, all kinds of therapy. So anybody who just keys into the word therapy may choose the wrong one, right? So they were trying to be a little tricky. Okay. So, but physical therapy, patella knee pads, knee sleeve, or taping. Everybody's aware that when you go to certain, we have one strength person in here, right? Did you do any patella strapping in your practice? Knees? Strapping, taping? Did you do any of that stuff?
I've used KT tape, but I've never.
Yeah. Yeah, so you have?
Wraps.
Somebody said they have. So basically it's where you try to actually tape the patella or tape areas where they restrict the motion of the patella, right? And just give it more stability. Okay? And so that's what when we talk about taping, that's what we're talking about. Knee sleeves, again, could be that patella knee sleeve with a cutout in the middle. Okay? If it doesn't have the cutout in the middle, will it compress the patella? Yes. So if you put that one on somebody who has patellofemoral pain and not the one with a cutout, could they actually make it worse? Don't be that person. Okay. Weight loss, obese, in parentheses. Okay. Remember, every pound here, 8 pounds here. Okay. Or down below. Down each knee. Okay. Makes sense? Operative, again, if you have patellofemoral pain, but you make the diagnosis, then you may need treatment of some kind, either for instability or maltracking. Okay. Avoid aggressive quad activities until later. So remember, the cornerstone of physical therapy, even though it's a hallmark, you start out with range of motion, right, and flexibility, and then progress on to strengthening. Okay? Because you may make it worse. Do you agree? Yes, of course you do. Okay. So when we talk about meniscal tears, okay, we talked about a lot of things in meniscal tear. And I told you guys that if I could give you a test that has 49 questions on meniscal tears and 1 question on patellofemoral maltracking, would I do it? Yeah. I might. No, I'm joking. but maybe throw in a couple of patella tendon, quad ruptures, stuff like that, right? But the important thing to understand about meniscal tears is that if you miss the fact that the patient has a bucket heel tear, that's not good for the patient, right? Because you just took a condition that us in orthopedics would grab onto, you know, take them to the operating room, tack it back down, make it good. They have a good prognosis. They don't have that increase in their arthritis into something that now is a chronic tear or a more significant tear, and they have a locked knee. That's bad, right? Okay, when you go back and you're looking at meniscal tears, just focus in on the fact that I told you guys that even though I provided supplemental slides, I'm not going to ask you to differentiate between parapeak, radial tears, horizontal tears. Not going to do it, okay? Because there's too much. I had to give you a lot of slides, right? I had to give you a lot of slices, excuse me, of an MRI. Have I done that yet in any exam I've given you guys? No. I can if you want, but I don't think it's like value added, okay? Because again, are you going to wait to get an MRI to diagnose the bucket handle tear? You're going to make that diagnosis on exam, correct? Because they have a loss of functional range of motion and or they're locked in a flexed or extended position. Okay, makes sense? So focus on the stuff I told you guys. When osteonecrosis of the femoral condyle, when we talk about osteonecrosis of the femoral condyle, this is not a vascular necrosis of the hip, correct?
Yes.
The answer is yes, okay? So when you're reading these questions, a lot of the answers sound similar, okay? So you may be fooled and tricked. Read the question, read the anatomy, read the description of the patterns of presentation, because would you agree that osteonecrosis of the femoral condyle a lot of times presents kind of as a prolonged, like the patient starts having symptoms over time, gradual onset, okay, and now, but is it sharp, severe pain when it's significant? Yes. So don't get that confused with other conditions that we talked about. Okay, look at the specific, excuse me, I can't talk. The specific patient presentations and the specific patient population. What age group gets osteonecrosis of the neofemoral condyle? Anybody remember? Is it younger or older patients? Older. And what patients get AVN of the femoral neck? Yeah, younger, correct? So read the question, read the age, okay? Differentiate, start thinking of those terms, okay? So I'm not 60 guys, but those are the guys that get osteonecrosis of the neofemoral condyle, right? Older gentlemen? Is it males or females? Females? Okay. Okay. All right. Start looking at these things when you guys are studying. I took a lot of time making the slides and differentiating things. Okay. If it's in yellow, sometimes it's the what do you guys say? That's the answer. Not necessarily. Okay. It's just a way for me to be like, you understand that this is a key point on this slide. Does that make sense? Like, if you understand this concept here, that means you understand this slide, maybe. Okay. Make sense? Then you'll be better guessers. Okay? Joking. So tendonitis versus ruptures, understand the presentation, also understand the physical exam findings. We went through those physical exams. We'll go through them in the lab next week. Okay? Good to go. Patellofemoral maltracking, and then you got patellofemoral pain. I'm sorry. There is no way for me to teach you this any differently than I have, because I can tell you right now, you guys are going to diagnose everybody with PFPS if they're under the age of 25, right? That's okay, because that means that at least you think it's not patellar instability, and you don't think it's significant patellar maltracking, right? You think it's more just patellofemoral pain because they started having overuse, or what they call overtraining, right? So they didn't train up, correct? But the history is going to differentiate that for you, okay? And then when you go back and you study specifically patellofemoral maltracking, understand that patellofemoral tracking is normal. The patella tracks in that groove normally. Therefore, maltracking can lead to a gamut of things. But what is the physical exam findings on the test question or the scenario that's presented? Where does it lead me to? Make sense? I won't try to trick you guys. I'll just kind of give it to you straight. You have to put it together. It's kind of like the impingement versus labral tear thing, right? The shoulder. You have to know, if I tell you this is positive and this is negative, that this is this one, not that one. Does that make sense? So when you go back and study, do it that way, okay? I can keep going, but I'm pretty sure that I feel comfortable with where we are in the lectures, okay? So if you guys are okay with it, we're going to call it, okay? Thank you.